Hello, everyone. Hello, folks online. We're happy that you've joined us. And hello, lovely audience in the room. We're really happy that you've joined us. I'm Pamela Collins. I chair the Department of Mental Health here at the Johns Hopkins Bloomberg School of Public Health, and lead our new Johns Hopkins Center for Global Mental Health. And with me is Ms. Afsha Lakhani, who's the Managing Director for our Center for Global Mental Health.
Hello, everyone. Thank you so much for joining us today.
And we have several of our faculty and leadership from the center in the room as well. But we'd like to welcome you to this first presentation, first offering of the center. And we are delighted that we have Professor Angela Ofori-Atta, who is visiting from Ghana. And she is a practicing, I hear cheers, go ahead. Professor Ofori-Atta is a practicing clinical psychologist, researcher, teacher, past chair of the Department of Psychiatry at the University of Ghana Medical School, and outgoing chair of the Ghana Psychology Council. She's an accomplished author of research articles and a book on trends in mental health research in Ghana. She co-leads the mHealer research, which is a digital intervention focused on faith healing camps, and the Escaping Poverty randomized controlled trial, where her cognitive behavioral intervention has been tested against conventional economic programs. She founded and directs PsychCore, a project which delivers psychological first aid in communities. She's previously held political office as Deputy Minister for Manpower Development and Employment, and she holds graduate degrees in psychology, MA and PhD from the University of British Columbia, a bachelor's degree in psychology and zoology from the University of Ghana. In service to her community, Prof. Angie hosted a weekly radio show called Beautiful Minds during the COVID years, which sought to build resilience and reduce the stigma related to mental illness. She serves on many boards, the Enterprise Group, Data Bank, Accra College of Medicine, and the Africa Leadership Initiative. And she's married to Ken Ofori-Atta, and they have 4 adult children. So I have known her for some years now. We collaborate on one of the studies that she'll talk about today. And I'm just really happy to see her here in person and here to tell us all about her work. So thank you so much. Please come.
Well, I'd like to start by saying a big thank you to Pamela for having me here and for your team and for the huge warmth that I've had a way to describe warmth that I've experienced here today. So thank you so very much. Well, my talk today is about optimizing sociocultural resources to extend mental health, integrating evidence, digital health, and spirituality in Ghana. Okay, do you want me to go back? Okay, all right. So in the middle of West Africa, the middle of the coastline of West Africa is where Ghana is. And we are in the middle, closest to the middle of the world, center of the world. So this is the Greenwich or Greenwich meridian, 0. And then the equator sort of is on this, just 4 degrees south of us. And so we are the country closest to the center of the world. We Ghanaians, that's how we think of ourselves. Okay, so the theme of our work, if you think about it, when I went back home after my PhD, I was the 2nd clinical psychologist in the country. And there was only one other. And so we just did everything that there was to do. So if you see it a bit scattered, this is the reason. But in today's lecture, we will be answering the question, where do people get care in Ghana? Where do they go to get care? And how have we reached them in the places where they've gone? So I'll talk about a public mental health intervention through cognitive behavior therapy. And then I'll talk about the prayer camp study, which we've called Joining Forces with faith healers. So that was the first time we did that. And then the third study I'll talk about is the digital mental health study, which is the mHealer project with Professor Collins, Pamela. Okay, so just a little bit about mental illness in Ghana. We're a population of about 31 million Ghanaians in 2021, at the 2021 census. And we presumed that about 13% suffer various forms and degrees of mental disorder. And I just recently got these numbers from the District Health Information System, the DIMS we call it. And if you look at it, it's covering 2018 to 2022 over there. And this is post-traumatic stress disorder. And if you look at the year 2020, it's steadily rises, and that's the year after COVID. So we can begin to trust the numbers. This is OCD, so it sort of doesn't really go up that much. If you look at schizophrenia, it steadily climbs until in 2022, we're at 25,000 approximately. And these numbers are important. I'll tell you why in a minute. This is for depression. It's sort of, it didn't go up too much, but that's not the reason I'm showing you these numbers. This is bipolar, and this is for generalized anxiety disorder. This is why I was showing you the numbers. So the treatment gap in Ghana is estimated between 95 and 98%. This is the number of people missing from our care. They don't come through to government services, which they should have access to. And why don't they come? They don't come first because we think the mental health literacy is poor, and the faith is that they can be healed. It's not medicine that will do it for them. And so this is a study from Ethiopia that shows an inadequate knowledge about mental health. I believe in psychiatric disorders as being contagious. If you live alone, that's good treatment for mental illness. And then with regards to causes, there's the belief in possession of an evil spirit, belief in God's punishment, belief in witchcraft. But there is a high correlation between being educated and having high literacy about mental health. And that's true in Ghana as well as in Nigeria as well. Okay. So then I again ask the question, apart from faith, why are they not coming through to us? And apart from faith, we know that patients are searching for a cure. They're not looking for management, and we offer management. We'll help you through this illness. But the faith healers say, we'll cure you, we'll heal you. And another reason, of course, is if they all came to us, there wouldn't be enough of us to take care of them. The professional resource deficits are 1.4 mental health workers per 100,000 people, compared with a global average of 9 per 100,000. Liberia has 1 practicing psychiatrist. Niger has 3, Togo 4, Benin 7, Sierra Leone has none, but Ghana has 60. And we still would not be able to take care of everybody who was coming through to us. Still, there are other reasons. There's limited policy and funding. If we wrote down the policies, we might follow them, but we don't have many policies written down on mental health. And we spend about 1% of our health spending in mental health compared to the 6 to 12% that the West does. And you know, in the West, the health budgets are huge. So you can begin to see. And then we have 3 psychiatric hospitals, and most of our funding goes to take care of the 3 psychiatric hospitals. We don't have many prevention programs. And we don't have sufficient data. So I'm taking you back to why I was showing you the data. 24,000, 25,000 people with schizophrenia coming through a healthcare system. That's 10% of those who need to come through. If you think of about 1% of patients with 1% of any population having schizophrenia. So we're not doing too well with the number we're able to take care of. But there's a cost that we need to remember when people don't come through a healthcare system. So many years ago, we had the Ghana Health and Socioeconomic Panel Survey by the University of Ghana and Yale University. And in it, they took 5,000 households. They got respondents from 10,000 people and responses from about 10,000 people. The neat thing about it is the first survey that included a psychological distress scale. So it's the first national survey of psychological distress. And the results were interesting. So about 20% responded to having mild to moderate psychological distress, people with lower incomes and education, women, especially disempowered women. But there are interesting economic implications. When you work with economists, this is what happens. They turned the absenteeism into money, and they said we were losing about 7% of our GDP. From people who just said, I lost 3 days out of the last 30 days. I didn't feel good about myself. I lost half a morning here. Somebody said 2 mornings there. And when they calculated it, it came to about 5.3 billion US dollars. So that's what we're missing with people not getting the care that they need. So we thought, okay, how do we show that if you have some mental health interventions, it'll make a difference? So with the IPA, my colleagues were in Yale at the time, they moved to Northwestern University. And would a cognitive intervention do the trick? Can we compare it to usual economic interventions? Well, so I was challenged to come up with this intervention that had 4 modules: how to listen and challenge thoughts, identify errors in thinking, replace harmful thoughts with more adaptive ones. That was 1 module. A communication conflict resolution module, healthy living, and goal setting and planning. The things we kind of take for granted because we're educated, but this program was going to a peri-urban and semi-literate population. We thought it was important. Anyway, we ran the intervention in interactive groups, 12 weekly meetings, groups of 10 to 12 male, female groups, because we were doing this in the north, mostly in the northern part of the country. And it was delivered by university graduates. So a task shifting kind of intervention. They met in classrooms, they met under trees, they met in churches. And the results were very encouraging. Less psychological distress, greater self-confidence, better mental health indicators. Interesting, because we didn't think that a CBT intervention would help normal people. These were normal people. They didn't have, anxiety, depression to any clinical levels. So it was interesting for us that we could still improve the mental health of populations like that. And the socio-emotional skills went up, about 0.28 standard deviations, cognitive skills went up. And days off from work due to physical health reduced by a third almost. So they should have done the USD equivalent of that. I should ask them to do that. So this is one demonstration which for us showed that we can intervene and we will have results for public mental health if we intervene. It doesn't matter whether it's with the middle class, the working class, so on, we can improve their mental health status. But let me move us to serious mental illness now. Where do most people go still? Okay, I think I can answer the question. Many people with mild to moderate mental illness are going to their churches and they're saying to their pastors, please pray for me. I've been having bad dreams or don't feel great. Please pray for me. And we have approximately 12,750 branches of churches. Not even sure what I mean by branches of churches, but at least that number. At least 33 denominations Christian. We haven't even included the Islamic mosques and communities in this. So the formal Orthodox churches have close to 15 million members, and the one-man churches have about 6 million congregants. Therefore, getting social programs through the churches is an effective way on a large scale to get things done socially. The WHO aims in 2022, and I think some of that work was done by you, no? I see. Well, so that, yes, so we have from that work about 1,705 faith healing camps in the country. That's a very conservative estimate. And then we have for children, I think we find many children who need special care in orphanages and special schools. But I want to concentrate on the faith healing camps. So this is one of the faith healing camps that we worked at. This is one of the largest in the country. At any given time, it might have between 100 and 130 patients in residence. This is our team working there in the first study that we did. But the nature of faith healing camps or the nature of prayer camps is this, the belief of healing through faith, a community's response to dealing with serious mental illness. So if I'm a pastor and I can pray for you and you can go home and you can be settled, that's great. But if you come back the next day and you say, well, I have a mother who has schizophrenia or has dementia, and we can't keep her at home anymore, he'll likely say, bring her, we'll pray for her, and we'll keep her for you. So that is a faith healing community's response to serious mental illness. They could be part of a big conventional church, like the Apostolic Church of Ghana, and then they have a part of their congregation or the part of their residence would be for people with serious mental illness. So there could be a one-man church. So there's a great diversity in resources, size, approach. And they are largely unregulated. The healing methods include prayer, fasting, laying of hands, teaching of the word, the use of herbal medication, and they're under-resourced, often funded through the main church, the charity giving, or when patients are healed, they'll come back, their relatives will come back, they'll be grateful, and they give offering of thanks. Before we started the second phase of our work, we went and walked through about 52 camps, and we found that about 36% of them had dedicated infrastructure for keeping patients, which meant that there would be rooms that patients could sleep in or rent and then attend church service and be taken care of. About a quarter of them were headed by women. About a quarter of them did not use forced restraints. About 74% of patients were not forced to fast in these places. And about 74% of the camps did not insist on their patients being fasting. And about 86% of the camps, they used herbal medication that they themselves produced. So not standardized in any way. And in about 91% of the camps, district psychiatric nurses were invited to come and see patients. And district psychiatric nurses are trained to diagnose and prescribe. So I put it in red because it was very exciting for us to find this. The only thing we worried about was if they're using their own medicine and they're also inviting the CPNs, the community psychiatrists nurses in, are patients being bombarded with medication, partly which is not standardized or which we know nothing about. And this is just to say that about in half the camps, there may be about 1 to 3 healers. So they're not big places. And there may be only about 4 or 5 patients per camp. And they may stay for up to 3 months or a year. So they're small holdings. So that's the nature of the prayer camps. And now I can tell you about the first study, which was a randomized control study, which we did in this largest camp, faith camp. We put together a clinical trial of psychotropic medication with faith healing practices versus standard faith healing practice only, and ran the trial for 2 to 3 years because the leader of the camp, the prophet, wanted to know if his healing mounted to anything. So he allowed us in as long as we would test his methods as well. And our theory of change was that with the use of medication in the faith healing camp, patient health outcomes would improve, training of patients would reduce, and the camp attendants' worldviews would shift to a more biopsychosocial religious perspective. So at baseline, we did a standard clinical interview with psychiatry residents, then randomized patients into controlled experimental group. Then we followed them baseline 2 weeks, 4 weeks, 6 weeks. And we did the main outcome measure was the pre-psychiatric rating scale. And on exit, the control group was offered medication and reviewed also every 2 weeks. The diagnoses that came through were the psychotic disorders, the bipolar disorders, depression, and comorbid substance use disorder. The sample was mainly male, 93 male, mainly divorced. 98 of them said they had children, and the education levels were between university and all the way down to primary school level of attainment. And that surprised us because we didn't expect to see university graduates in the prayer camp setting. So that was interesting for us. I've just picked one graph to show you the change score for the control group, the experimental group versus the control group in pink. Yes. And so the experimental group did better. We knew they would do better. We knew that medication would lead to better health outcomes, but we were demonstrating to the faith healers that this was the case. It was also the first time that anybody was running a control trial in a faith healing camp. Anyway, the effect size was moderate, 0.43, and I think that's a respectable size for even better controlled environments. So we did show the people in the prayer camp that bringing in medication would be helpful to their patients and to them. Now, there was one patient who said, one healer who had 2 patients come in, brothers, first time schizophrenic attacks or experiences of schizophrenia. And he said to me, after they'd been on medication for 2 to 4 weeks, he said to me, for the first time, I saw them as human. Now, that made me very sad. It still makes me sad, but I couldn't help thinking, okay, then we achieved what we wanted to achieve. And another one said, why do you need a control group? Because they had to wait, to be part of the study. Why do you need a control group? Why not treat them right away? You don't need a control group. And this was towards the end of the study. So I figure we did achieve the demonstration effect we wanted. And so you go back to the figure that I showed you, and you see why I put it in red. 91% of prayer camps that we visited 5-6 years later now bring in the clinical workers to give medication. So we feel like that was worth a demonstration. There are challenges to this model. There still are prolonged and forced fasts in many of the prayer camps, but they don't admit that that is the case. There's still the use of physical restraints, and the law really forbids it, but they say, how do we not? Because if we don't, they'll run away. And if they run away and they get lost, then what do we do? Is their life better off? And so the importance of funding for infrastructure is really important. Then there are abuses arising out of the illness, the patient's agitation. Patients are they don't conform to rules. It's the nature of serious illness. And so how are they going to become professional if they're going to be taking care of people? And so at the end of this study, I said to myself, I'm a clinical psychologist, and I've come up with a medical intervention, and I can see that we would need some psychological interventions. So enter the team from University of Washington, including Pamela, and they think we can scale up by going digital and putting psychosocial interventions on an app. I have to admit, I thought it was pretty, up. But they came and they spoke to the healers, and they got something going, some magic with the healers, and they came up with this intervention. But it wasn't like that at all, because actually in Africa now, Nigeria, Ghana, South Africa, Kenya, we have telecom density exceeding 100%, which is people have more than one mobile phone. They're digital already. So, and by 2025, we'll have about 1.05 billion connections in Sub-Saharan Africa. I mean, we're digital already. We have digital apps, particularly in South Africa, lots of digital apps. And since COVID, it's gone haywire. So this is our intervention. Third one I wanted to tell you about, combining mHealth and nurse-delivered care to improve the outcomes of people with serious mental illness in West Africa. Meet our narrator. It's pretty hip. So our research team, including Professor Collins, has developed a dual-pronged intervention package. We call it the M&M. mHealer is a mobile health program designed to train healers to deliver evidence-based psychosocial interventions while maintaining safety and patient dignity in practice. And then it's combined with nurses visiting nurses who directly deliver the pharmacotherapy to the patients at their prayer camps. So this is what, on your right, this is what the Android phone looks like. It's very simple. This is the interface. Just the pictures show you where everything is. It's audio, it's visual, and short videos. And so you don't have to be literate to use it. And then the neat thing about it in the middle is the healers can actually track the patient's progress with the use of emojis. And I think that's what excites the young healers the most, because they can actually keep track of up to, I think, 21 patients at a time on there. And then you look on your left and you see what the human rights looks like. This is the one the healers are not happy with. Everything else they say they're happy with. This one, they're like, what do you want us to do? How do we keep our patients safe? You say we shouldn't change them. Where should we put them? So that is the dilemma. That is a real dilemma for them. And the videos are in both English and Twi. Twi is our most widely spoken language in Ghana, and they choose between one of them. We've done an optimization phase. We have, it was a single arm pre-post field trial of the experimental condition in one prayer camp. We had 4 healers. Each of them received a phone with the app on it. We had only 15 patients for the trial, and we only were looking to see if we could create flow, with all these people we were bringing into the camp. And the outcomes we measured were the psychiatric symptoms, psychological distress, shame, and days chained. And so, okay, I don't expect you can make any sense of this, I'm sorry. But I just wanted you to see the number of green arrows on the left. And those are all significant at a level P less than 0.001. We were very excited about it. And those 6 arrows were for the brief psychiatric rating scale and the BSI. These are all measures of symptoms, psychiatric symptoms. Then the brief distress scale, other as shema, days in chains, and internalized stigma or mental illness. So if we can do this in 2 months with medication and with psychological intervention with the healers, I think that's pretty good. So we're in the 3rd year of that trial. And so the first 6 prayer camps, there are 18 camps. We've done the baseline on all of the 18 camps. We've moved into the 2nd phase, and the first 6 camps are in the M&M phase of the trial. I think so far, we hope to do 360 patients. So far, we're almost at 200 that have gone through the trial. Okay. So when I reflect on these 3 strands of work that we've done up to this point, what do I conclude? I have to conclude that research has the power to change policy and practices for the good of patients. So now we know it's no longer a strange thing to ask a nurse to come and see a patient in a camp. It's actually expected. So that's we're very happy about. The second is, as researchers and academics, we don't have the budgets to do this kind of work. So, or the budgets to just, or the power to just wave a wand and get it done. But the power of demonstration in small projects is really, really important. And having the IRB behind us, the IRB first for the University of Ghana has a very powerful IRB in the Noguchi Institute. It's a global institute and it does all our IRBs. And so when they said, yes, you can go ahead and work in a faith healing camp where there are patients chained, and they gave us feedback to make our science better. Then we knew, and the University of Ghana gave us money. That was just amazing. If you know the University of Ghana. So yes, we got, University of Ghana gave us money. Our colleague in Yale gave us a sliver of his research grants, and we got money from one of the corporates in Ghana as well. So we were very fortunate with that work. But having the university behind us and having the IRB say you can go in made it possible for the Ministry of Health, the Ghana Health Service, to say it's okay. All right, we'll see what you come up with, you go. So that's the power of academia, I think. Then spiritual practices, we learned that spiritual practices are impacted not only by the spiritual, but by the mundane. Shackling a patient has nothing to do with the spiritual. One of the things in the video is it asks the faith healer, what would Jesus do? They don't like that question at all. They're not happy with it. And so, but we also understand the practical that they're dealing with. And so it's been a lot of learning on our part. And I think it wasn't easy to do this. Sometimes we were afraid we would get in trouble with our colleagues. you know, but having, like I said, having the university and the IRB say, okay, if you don't go in there, who will? If you don't do this work, who will change centuries of practice? So that's it. Thank you very much.
Thank you so much. We have lots of time for discussion. So please, I want to see, do we have another mic around? I don't think so. I think we'll do the roving mic and see if are there questions.
Great talk. One question about the breakdown of psychiatric systems amongst the different education. You mentioned surprised that the individuals from the university were in the group. Did they happen to have a cluster of certain symptoms or ratings of depression or schizophrenia? Did you look at that group in particular?
Thank you. No, we didn't go back and look at that data. And we can still do that. But the surprise was not that they had serious mental illness. The surprise was that they were in the faith healing camp. Given the level of education, we would have thought that they would have more understanding about the mental illness, but no. If we go back, I would guess that some of them had been brought by their family members against their will, because the family members didn't know where else to take them or couldn't afford to take them anywhere else. That would be my guess. Yeah.
Thank you so very much. You spoke about the impact of the faith healers. You spoke about the impact on the patients. Did you learn about the beliefs and opinions of the family members and the others in the community, and whether over time that they're shifting beliefs, norms around mental health more generally, or even around serious mental illness, and how this is impacting not just the peer community, but the community surrounding the families?
Yeah.
Thank you. Yeah, we haven't looked at that. And that's a very interesting question, because I think we are in the M&M phase of this study, and we think, but we don't know yet till we've looked at the numbers, but we think that as patients get better, they leave the camp. And so we probably will find fewer completed protocols in this phase of the study, which means we have to find a way to understand what's going on. Because if you bring your relative to a camp and they're getting better and they're getting better on medication, then why are they there if they can have access to medication from home? Because these places are very rudimentary, very, is that the word? Just very basic places.
Thank you. This is very exciting. Such a great example of contextualizing science and going to where the problem is and solving the resources there. I'm just curious, given the stigma of mental health, the increasing involvement of non-clinical professionals in care for patients, how is this study, especially when using confidentiality among patients' diagnosis and see what information is going out?
Well, I also wanted to ask about this.
Yes, okay, thank you. So we have the clinical team and we have the research team. And the two are not supposed to be talking to each other. Well, they don't have much to say to each other, actually, but the data sets are separate. And so the clinical team is the psychiatrists, the residents, if you like, residents and medical officers come, they do their assessment. That goes into a separate database. So that's not discussed with the research team. But everybody is aware that they're supposed to be, we have the training going on that they should not be discussing patients and patient confidentiality. They go through a consent process, and it's hard getting consent sometimes from a patient who is, how do you assess that they are competent enough to give consent? Is it assent? Do you ask their relatives for that? Do you ask the faith count for that? So we've been struggling with that. We have procedures that we follow. We try to follow very strictly with that. So yes, we do try with confidentiality.
We don't tell them anything. They're not happy with that sometimes. Some of them are very cooperative.
But one or two give us a very hard time. And I think we learn more from them. The guys who give us a hard time. Yes, it's their come. Yes, the patients are theirs. And they have a right to. But we're like, no, you know, well, the IRB says, what is an IRB? Why? You know. But that's community work. So.
When they lock their doors to you.
So far, it's only one who's given us a really hard time. Yes, but like I say, we learn a lot more that way. She kind of, and then she lets go. Yeah. Sure.
So. The questions online, the first one is, do you know why there's such a high prevalence of schizophrenia?
Oh. I don't think it's high at all. Because if it's 1% of every population, a little less than 1% of every population in the world has schizophrenia, then for 30 million people, we expect about 300,000. Am I right? 1% of 30 million is about 300,000. And we only have 25,000 coming through in the database, the national database, which is just 10% of what we expect. It's not
Not as high.
It's not. Yeah.
All right, the next question is, this is great. Wondering how often such prayer camps use restraints only when necessary. It looks like most of them use that.
I think that may be because most of the patients with psychiatric illness are coming to them in the very active phase when they cannot be managed at home. And they'll use it because it's the only resource they have for these students. Now, when they come, they use the chains and then they call for the district psychiatric nurses to come in. And so then they come, they assess, they treat, And after a few days, patients are out of chains. But we do know that if the patients don't conform, in some cases, that there is punishment like that. And so we think that's where the act comes in. And the leader knows that, okay, I know I'm getting angry here. Let me give myself a time out, for instance. Then maybe there's more forbearance, more tolerance. Some training for that is on.
Thank you so much for your presentation. I'm glad you're sharing this with Ghana and it seems to be improving my cognition. So I have two questions. So the first being, have you thought about essentially training or teaching people how to use mHealer that are family members? So like once they have, I guess, kind of a program, they can sort of get that treatment happen. And then also the interface looks really usable, right? And so thinking about potentially happiness and feeling up for, you know, maybe adolescent populations or other populations that are suffering from mental health and things that we thought.
Yes, actually, we've been thinking, oh, why don't we just give it to family members as well? You know, but we have to test it. And then in these conditions, we have a little bit more oversight than if, you know, and if you have to prove that it's safe, it's workable. So once we do all the standardized things and we say that, we think that we show that it's okay, then I think that would be a good next step. Pamela, good next step. Yeah. There's another question. There's another question here as well.
Okay, thank you. So, in most cases, the pain of medical assistance, something that's distinct from this happens. So, the pain of higher density of traditional density of therapy, as well as the one so, very much excited, indicated that of the field organizations and various sets of nurses who can practice the patients. So my question is, if you extend the research for the and how does it go? We have similar kind of contribution to treatment and traditionally less. We do not share. And the second question was about whether patients and so late recommendation, whether they're able to, you find that evidence of this shooting and training, let's say, we can use that at the same time, this shooting, what factors are
Yes. Okay, I'm smiling because this information comes from Dr. Bing's work in that first study, in which, remember when I said they're looking for miracles? They're looking for a cure. So we walk into that first faith healing camp and he's like, oh, this is my colleague, he's a psychiatrist. And he says, what are you doing here? You're seeing his patients there. So, doctor. So very happy but embarrassed reunion on both sides. And that's when we learned that, yes, our patients do go to the faith healing camp. So they go where they're comfortable, where they need to be, where they get help, what they can afford, What is accessible, we know, yeah, that's when we found out. Thank you. And we haven't included the, how do you call them? The traditional healers, not yet. Not yet. I think we needed just a little bit more control.
We're gonna take one more, and then we're gonna go back to the online.
Hi, mine is more like just an informational question. I was wondering if you could say a bit more about what's your answer, right? Like, what do people do there on a daily basis besides that very strange? Like, usually how long do they stay, how many people are there, like, they just don't have a very good sense of, you know, who's the personnel, like, who takes care of the people, just like more of a,
Okay.
yeah.
Okay. So if my daughter is listening to me, that was the exact question she asked me. She said, I think you need to say a little bit more about the prayer. Yes, okay. So on a day-to-day basis, the prophet or the chief, let's say the chief religious leader may not have much to do with our patients, the psychiatric patients, but there are junior pastors or people hired to take care of them. So if you're from the perspective of the patient, you may do your self hygiene, take care of yourself. You may clean your surroundings. You may attend the prayer sessions, maybe early in the morning or whenever it is they're done. That's it. That's what you do in a camp. But I think as you get better, if you want to, if there's like it's a farming community, you may join them to do that. But otherwise, there's nothing much to do. It's like being in a hospital and sleeping the whole day. Not exacerbate that I know of, but I think if a patient is really disturbed and there's a loud prayer and casting out of demons and so on, that could be very distressful to patients. Yeah. Yeah. You're asking all these questions. They're very interesting questions. We need a stronger qualitative answer to study. Yeah. She's getting all
Alright, I'm gonna ask one question online and then we have a couple more later. So this is Leo from Sweden. Thank you, Professor, for an interesting presentation. Are you doing any research where healers are allowed to treat patients in mental hospitals? Is there a demand for this among patients in the hospitals? So bringing them in for the hospital.
Oh. Like they are bringing the app into the hospital.
The healer.
They're bringing the healers to see what we do in the hospital. Oh. Now that is interesting. Yeah, to bring them, even if it's on tour of the hospitals. Yeah. No, we're not doing it yet. But yes, why not? That's very interesting. How could we do it? Okay, thank you for the suggestion.
So this is great. Thank you for the presentation. Really good, really well put. I wanted to hear you comment a little bit. One of the things that we learned in this data are that the healers appreciate people managing medical issues, but they're also very clear that there are medical issues and there are spiritual issues, and that they want to manage spiritual issues. So somebody can come and maybe a psychiatric nurse can deal with the medical piece, but they still feel there's a spiritual piece that needs to be dealt with. So it's kind of this negotiation, right,
Mhm.
between the two forms of care,
Mhm.
so that those are taken care of.
Mhm.
But I just wanted you to kind of,
Mhm.
I think there's an interesting complexity.
Mhm.
How do you take care of this?
Yes. How do you determine that the symptoms are psychiatric and not spiritual? And I don't think we have found an answer to that except to say, well, it looks that, you know, the patient symptoms look like what we work with in the hospital setting, and we are able to make a difference. So we say that, okay, if you give us the opportunity, we will do the best we can. And we feel like even if we don't heal completely, because we know we don't get complete healing, then the spiritual can be even more powerful. So we try that conversation, and I think sometimes they see it. But they also have people there who have other chronic physical illnesses. And that they know that it's not all physical illnesses that are healed by medicine also. So it's a very interesting, you know, it's not a tug of war, it's a tug of ideas and minds that we have to do to keep going in this work with them. A lot of respect, a lot of understanding on both sides, a lot of humility on both sides to get it done. Yeah. But I just wanted to say one thing about bringing the healers into hospital. In one of the projects that we did, it was also a demonstration project in the northern part of the country. It's not here, but we did a lot of mental health education with health workers, so doctors, nurses, health administrators in the northern part of the country. And we brought them to the psychiatric hospital to see mental health. A couple of them became psychiatrists. A couple of the doctors went into psychiatry after that. And I think they did a lot more mental health care in the northern regions as a result of that. But we didn't write it up then. We were not interested in writing up in those days. We were just doing.
All right, one more question and then we'll wrap it up with you.
It's more complicated. It goes back to the idea of university hospital setting. But where you have as always research, integrate the communication academics, integration academics.
Yeah.
So the purpose of this, they are
That's true. Yeah.
And if you look at the terms of the patient, if you center care patient, and we think about the voice of the patient, right? If you ask the patient, what do you think is causing your mental health? They might tell you, I think there's a glitch.
Yes,
There's
yes.
this stability or cynicism of the person. So we kind of have that kind of we have the kind of this attending to the private capacity of what they will use. And it's also important that take into consideration what the patient is the cause of their disease. Whether the thing is biological or the thing is sociocultural or social. you should be able to have that kind of activity or holistic approach to your expectation. I think that's something that is specific about it. It's not about it.
Yeah. Mhm. Sure.
Yeah, just wanted to add on to what he said, that there is a people from Ghana written one Isla week, where she also did go to psychiatric hospitals, and many of the patients would say, like in the local language, a joke and hypochondria. So a little bit of medicine, a little bit of prayers, meaning that the patients themselves do understand that there is a pluralistic approach
Yeah,
to addressing some of these now.
that's right.
So.
So we do have time with Professor. So we can all continue the dialogue, but I do want us to formally close out the session today, so we can also look at the online posts, so.
Just thank you. Just thank you. Thank you for your interest and for your suggestions and comments. Shall take them on board. Thank you.
And in the spirit of thank you for being here with us today and for all the wonderful conversations you've started here with us. And thank you so much for making the visit out here. We are so grateful to have you at Hopkins. So thank you so much for being here. And thank you all for coming. There is still food in the back, so please eat. There will be to-go boxes set out, so please take some food with you and continue the